دمياط. بنتوجه بالشكر الجزيل للاستاذ الدكتور اسامه ناجا. الحقيقه هو في اجازه هنا عمله في جامعه تكساس في امريكا، وهو في اجازه حاليا، والحقيقه لم يبخل بوقته، يعني الفتره اللي قعدها معانا حب يفيدنا ويدينا من خبراته. فطبعا شكرا جزيلا، ودايما يا رب العطاء المستمر. نشكر الدكتور اسامه ناجا، الحقيقه يعني فرش لنا الدنيا جميله هنا، والمكان اخترناه لان ناس كتيره قوي قوي بتعتز بالمكان هنا وبالقاعه، وطول عمرنا التدريب هنا كان له مكانته، فالحمد لله رب العالمين. بنرحب بالجميع، وان شاء الله الناس باذن الله على وصول. مش عاوزين نتعطل.
طمنا عليك، الله يخليك، متشكرين جدا، الله يخليك، متشكرين، الله يكرمك.
الحمد لله رب العالمين، والصلاة والسلام على رسول المرسلين وعلى آله وصحبه والتابعين. اسمي مصطفى أطباء الرياض، وفي مستشفى مدرسة الخصوصي. نرحب بضيفنا العزيز فاضل الأستاذ الدكتور أسامة ناجا. ويقول العظام يعني كلكم متابعين صفحته، متابعينه أستاذ طب الأطفال جامعة تكساس أمريكا من الرياض، وله سنوات طويلة في أمريكا، وهو في أجازة حاليا، وهو اللي عرض علينا يعني مشكورا ربنا يكرمه، عرض علينا إن هو يدي هذا الكورس، فطبعا جزاه الله خير كده ورحبنا. والنهارده يعني بتكلم بقى في البيت، هو جاي من القاهرة، يعني هو من القاهرة، جاي النهارده الصبح من القاهرة، يعني كنا فينا، فربنا يكرمه ويعرف مش عايز قلت لنا عشان دي ان شاء الله بنلتزم بالوقت. الدكتور أسامة فاهم ان احنا الكورس حوالي 8 ايام، قلنا يعني تباعا، فاتفقنا على اليوم الاول ده اللي هو الكرسي، والاثنين الجاي ان شاء الله هنا في نفس القاعه في ماده الكرسي. وكل يعني بعد كده نحط الجدول في بعض هنا نحط مقابل ان شاء الله، لكن يعني بين المقابل هنا وبين المقابل هنعمل عليها او هنعمل خلال يعني نتفق على الكلام العام الثاني. البدايه ان شاء الله النهارده Pediatric الهيماتولوجي، والاثنين الجاي ان شاء الله النهارده الهيماتولوجي، والاثنين الجاي ان شاء الله الهيماتولوجي.
how to apply hematological disorder to your practice, your practice. Each disorder will be preceded by a clinical case scenario. There is no financial support or pharmaceutical sponsorship for this presentation, and a special thank to Dr. Osama and Dr. Ashraf al-Basir who made this meeting possible. It's very important when you have when someone bring you a CBC in your clinic to know this CBC has a lot of knowledge, a lot of important information you can obtain from just the CBC. The more you know and the more you learn, you will know that the CBC is very beneficial. Like for example, white blood count can be elevated in many conditions, like most commonly infection, leukomoid-like reaction. When the white count is low, neutropenia, and we have many types of neutropenia, and we'll discuss that in this lecture. Also, neutropenia can be a sign of sepsis in neonates. Okay, so white cell count by itself, it has a lot of diseases goes around. Red blood cells is the red blood cell mass. The function of red blood cells to carry oxygen, to provide oxygen to the tissues. So if the red blood cell mass is decreased, this is called anemia. Anemia means that red blood cell mass is decreased in the entire body, so the child will be hypoxic. Red blood cell can be normal or elevated in cases of thalassemia, but usually reduced in iron deficiency anemia. Okay, so it's important when you look at CBC, if you see red blood cell normal or slightly elevated, you are dealing with most likely thalassemia, not iron deficiency anemia. And the hemoglobin and the hematocrit, they will be reduced with the red blood cells. Okay, and MCV is the mean corpuscular volume. Just the mean corpuscular volume, you can get a lot of information from the mean corpuscular volume, which it will measure the size of red blood cells. If they are small, microcytic, or normocytic, or macrocytic. Mean corpuscular hemoglobin concentration, this will measure the concentration of the hemoglobin in the red blood cell. Usually reduced in iron deficiency anemia, but will be elevated in two conditions. In immune hemolytic anemia will be elevated, and also in spherocytosis, because this red blood cells they will be smaller than normal. So this is the only two conditions will make the main corpuscular hemoglobin concentration elevated: spherocytosis and immune thrombocytopenia. RDW will give you the measurement of red blood cells and the distribution. If you have variability in the size of red blood cells, this is a good sign of iron deficiency anemia. It's called the red blood cell width distribution, or distribution width. Platelets is acute phase reactant. Same like CRP will be elevated when there is inflammation, like case of Kawasaki. You can have thrombocytosis. You can also have thrombocytosis in cases of iron deficiency anemia. When the platelets are low, this is also can be signs of sepsis in neonates. When you have any neonate in NICU with platelet count less than 100, you have to suspect this is a possibility of sepsis until otherwise improved. Thrombocytopenia also can be a sign of immune thrombocytopenia, or previously well known as thrombocytopenic purpura, idiopathic. Also, platelets, when they are low in a child of 4 to 5 years, you have to think about leukemia. Is a very important and can be the beginning. Main platelet volume, also the size of the platelet is very important. Platelets are usually large in immune or autoimmune hemolytic anemia, and they will be very small in rare cases like Wiskott-Aldrich syndrome. They will be giant in Bernard-Solier syndrome, where the platelet adhesion problem, the child will have some bleeding disorder. It's rare, but you will see the platelets are giant. So this is important for that. Neutrophil also will reflect the white blood cells, and you will count, to make a benefit of the neutrophil, you calculate the ANC, which is the absolute neutrophil. So neutropenia, also we'll discuss that. Lymphocyte, very important. Lymphocytosis can be a sign of infection, especially Epstein-Barr virus. Cytomegalovirus can give you also atypical lymphocyte. Lymphocytes also, when they are elevated, can be a sign of lymphoma or Hodgkin. Monocytes, they are important for when they are elevated for chronic bacterial infection like tuberculosis. Eosinophil, they are elevated usually in cases of allergies, eczema, okay? Can be also elevated in asthma. Eosinophilia also can be elevated in parasitic infection. So a lot of information just from CBC, by ordering just CBC. You can reflect and understand a lot of things from just CBC. Eosinophil also can be elevated in some cases of eosinophilic esophagitis. Okay, so, but to confirm the diagnosis, you have to do the biopsy from the esophagus. Basophil or basophilia also can be elevated in some cases of cancer and some allergic conditions. For example, if you have this case presented to you in your practice, and this child is having this petechiae in the legs all over the body, complaining of joint pain and abdominal pain, and you did CPC and the CPC is normal, what is the most likely diagnosis? Excellent. So هنا شو line purple? I wish I have something to say. So you have this child. This is a patient of mine. He has ecchymosis in the arms, in the legs, okay, and they are also suffering from epistaxis, recurrent nosebleed. The CBC is normal, except the platelet count is low, 7,000. What is the most likely diagnosis? ITP. ITP is immune thrombocytopenia. This is the new name. So you based your clinical diagnosis based on just the CBC. So when you have cases like that, you can just order CBC. You don't have to order a lot of labs. Just CBC, you will understand the problem. So we have the same case, same child with epistaxis, ecchymosis, petechiae all over the body, but the white count is low, very low or very high, and you have some sort of anemia, and the platelet count is 20,000. This is a case of, most likely, leukemia. So we'll discuss first the anemia. So anemia, as we go back to medical school, anemia is decreased production or increased destruction. It can be because of iron deficiency anemia, folic acid, and B12. These two, they will give you macrocytic. This one will give you microcytic. Infiltration of bone marrow with abnormal cells. This will crowd out the normal cells, and the bone marrow will start or will not be able to produce normal cells, and this is what is leukemia. Or lymphoma. Bone marrow failure or exposure to toxins like chemotherapy will cause bone marrow suppression. Effective hemoglobin like thalassemia. Okay, we have if the effect in the globin will give you alpha thalassemia. If it's beta globin will give you beta thalassemia. In the membrane will give you spherocyte. It will give you spherocytosis. If enzyme deficiency will give you G6PD. If you have antibodies against the platelet will give you immune hemolytic anemia. So let's take this case scenario. You have an 8-week-old with hemoglobin 11 grams per deciliter, normal MCV. Reticulocyte count is slightly low. Normal direct and indirect levels of bilirubin. Negative direct antibodies, so it's not autoimmune. The infant hemoglobin was 15.8 grams per deciliter at birth. What is the most likely cause of hemoglobin drop? Anyone can? Huh? Yes, exactly. Perfect. So it's physiologic anemia of infancy. So if you incidentally order CBC for 2 months old and you see the child is having anemia and MCV is normocytic, this is normal. You don't need to give iron. There is no microcytosis, normocytic. The child is feeding well, gaining well, thriving well, no problem. You don't have to do any further investigation. Reassure the parents. No iron. Unless if the child is exclusive breastfed, you start the iron normally at 4 months. So here is when the baby after birth, the baby will be exposed to more oxygen, more adult hemoglobin start to rise, fetal hemoglobin start to go down. This will down-regulate erythropoietin, will make the bone marrow transiently will make less red blood cells between 8 and 12 weeks. So by 3 to 4 months, the level start to go back to normal. And usually the level will be between 9 and 11 grams. Will not be a severe anemia like 7 or 5. Usually will be around this range, 9 to 11. And the preterm babies, they have more exaggerated physiologic anemia because of the frequent phlebotomies, frequent testing, and it may appear earlier at 3 to 8 weeks, and all of them, they are self-limited, all of them will resolve by 3 months. So when we look at the red blood cells, they are different than adult. Adult, they do 80 to 100. For pediatrics, you do, for microcytic, you do 70 plus the age. So if you have 8 years old, the normal MCV for this child, 78. So if the MCV is 75, this is microcytic. Okay, normocytic between more than 70 and less than 100. They base the size of red blood cells based on the mature nucleus of lymphocyte. If it's the same size, it's normocytic. If it's smaller, will be microcytic. If it's larger, will be macrocytic. If you have a newborn with MCV 95 to 120, this is normal. So if you have one newborn with 110, this is not macrocytosis. For newborn is normal. But as they grow, start to normalize, and this based on 2 years and older. But between 6 and 2 years, between 70 and 86, this is normal. So we have to know the age variations. To understand microcytic anemia, and this slide is hemoglobin, is heme and globin. And the heme is 2 parts, iron and protoporphyrin. If you have deficiency in iron, heme will decrease, hemoglobin will decrease. This will give you microcytic anemia. If you have protoporphyrin is decreased, protoporphyrin has to combine with iron in order to give you heme. So any decrease in protoporphyrin, like in lead poisoning or sideroblastic anemia, will decrease the heme, will decrease the hemoglobin, and will give you microcytic anemia. And the red blood cell will start to divide more, to try to divide the hemoglobin between themselves, to make the red blood cells as pretty as possible, to be looking better. So it will have you will have one extra division. And the opposite for macrocytic. Because of the macrocytic with DNA synthesis, they will divide less and they will stay large. Because the erythroblast from the bone marrow is originally large. As they mature to reticulocyte and red blood cell, they will start to divide more to be normocytic. But if they divide extra, they will be macrocytic. Microcytic, if they divide less, they will be macrocytic. Count is slightly loosely used, it's 4 millions, and the hemoglobin level is very low. Mean corpuscular volume 59 femtoliter is very low. MCV is very low. Platelet count is slightly elevated, so there is some thrombocytosis, and the reticulocyte count is low for this age. What is the most likely diagnosis? Iron deficiency anemia. This is a classic case of iron deficiency anemia. So iron deficiency anemia, if you, when you have a case like that and you are in doubt it could be iron deficiency anemia or thalassemia, you do the Minzer index. Minzer index is suggestive but not diagnostic. So it's a good start to use Minzer index to know which way to go, what lab to order next, but will not confirm the diagnosis, but will tell you what to do next. So Minzer index for this patient 59, the MCV, divided by the red blood cells in million, divided by 4, will give you 14. If it's more than 13, you are dealing with iron deficiency anemia. If it's less than 13, you are dealing most likely with a case of thalassemia. So as we know, the iron deficiency anemia, because of if you have exclusive breastfed mom and she's not giving any iron, you may have iron deficiency anemia because breast milk is deficient in iron. This doesn't mean that you tell the mom not to breastfeed. Breastfeeding is the best milk on earth, just so you add iron to the baby at 4 months. Lack of iron-rich food, consumption of large amount of milk. Why? Because milk can cause micro-injury to the intestine, and you have micro blood loss. So you will have loss of blood, and you will not see it, but the child will lose a lot of iron. Also impaired absorption, like cases of celiac disease, commonly associated with iron deficiency anemia. So if you have a child with iron deficiency anemia not explained, it's important to check for celiac. Also, cow's milk allergies. The babies, they have allergy to cow's milk. Lesion like Meekle's diverticulum. The child will have pinless, frank bleeding or blood in stool, frank blood in stool, and is pinless, is Meekle's diverticulum. Or bloodsucker like hookworms. Menstrual for adolescents, they commonly they have iron deficiency, and the new guideline now to supply all adolescent girls with iron, even if they do not have iron deficiency anemia as prevention. hemoglobinuria, like paroxysmal nocturnal hemoglobinuria, rare diseases like Gold-Pasture syndrome or pulmonary hemosiderosis. The signs of anemia is because of hypoxia mainly. Everything because of lack of iron. This child cannot have normal oxygen. They are hypoxic all the time. They are pale because of low hemoglobin level. They have chylonychia. Why chylonychia and iron deficiency anemia? Because the iron is important for the nail growth. So if they have less iron, they have a brittle nail and they will be spooning in the nail and what is called chylonychia. They will have headaches because of lack of oxygen, irritability, poor school performance. They will do poorly in school. They are sleepy, loss of appetite, tachycardia is a reflex. There is low oxygen. The heart is trying to make up the oxygen by speeding the heart rate, and also systolic murmur or flow murmur like Still's murmur will be more exaggerated. In iron deficient anemia, there is microcytic, and the main corpuscular hemoglobin concentration would be low, okay, and the elevated platelet count in some cases, normal or elevated white blood cell as a reactive. So the iron will be low, ferritin will be low. Ferritin is the storage of the iron, the iron storage, okay? And the TIBC is the transferrin, it tells you how much or how many transferrin is available to bind with iron. It's called total iron binding capacity. And the soluble transferrin receptor will be elevated. This is the receptor for transferrin itself. And Minzer index will be more than 13. So let's take this here. In iron deficiency anemia, ferritin will be low. What TIBC? High. Soluble transferrin receptor level? High. And the transferrin? High. The transferrin, the liver will produce a protein is called transferrin, is the transport for iron, trying to catch iron, any iron in the circulation, looking for iron will be elevated. And the iron, low. And the transferrin saturation, low. Why? Because the transport is trying to find out, but there is none. So it's just going around empty. So when the iron is high, transferrin saturation is high. When the iron is low, transferrin saturation is low. So we'll be here, whenever the ferritin is low, TIBC is high. Ferritin is low, TIBC is high. Whenever the soluble transferrin is elevated, also transferrin is elevated. Okay, whenever the iron is low, transferrin saturation is low. So in the peripheral smear, you will see here, this is a microcyte, but is very magnified. So if we have a lymphocyte nucleus here, this will be smaller. You can see the exaggerated halo in the peripheral smear, less hemoglobin. So you can see the central color is more exaggerated. Is the red blood cells are very pale, less hemoglobin, and different sizes, larger, smaller. This will give you the RDW will be elevated because different sizes. What are the best initial studies in case of suspected iron deficiency anemia? Just you want to order something for the patient as initial. Huh? Yeah, that's perfect. So ferritin, iron panel, it could be, but if you want to order something like economic to give you an answer very quickly, yeah. So just CPC, repeat count, ferritin. By ordering that, you will understand if it's iron deficiency anemia, if it's thalassemia, you will understand everything. Okay. So if it's a case of thalassemia, you will have the ferritin normal. So treatment of iron deficiency anemia, we give ferrous sulfate. The new dosage is 2 to 3 milligrams per kilogram. Why they lower the dose from 4 to 6? Because they found with several studies that giving higher dose of iron will increase the hepcidin or hepcidin from the liver, and hepcidin will block the absorption of iron. So they found a better result with giving a lower dose, and also less side effects in the stomach, less constipation, less GI irritability. And the best is to give it once a day. Several studies was done to give it once a day, better than giving the iron in 2 doses. So it's better compliance. They will not miss a dose. It's easier for the mom, and also better to have a better iron in the available in the circulation. And to give it an empty stomach, and to enhance the absorption will be with orange juice or lemon, anything citrus. So if you have a case of iron deficiency anemia, they come to the best follow-up in 4 weeks or 3 weeks. 4 weeks is fine, and you give them to order a CBC. You will see the hemoglobin and the hematocrit start to rise. If you see the hemoglobin rise in the 4 weeks follow-up 2 grams per deciliter, you know that they are responding to your therapy very well. And after that, you will see the microcytosis and the hematocrit and the serum ferritin start to improve. Then you have to supplement with iron for another 3 months to replenish the iron storage, to correct the ferritin. When to do blood transfusion for iron? Most cases of iron deficiency anemia, they do not require blood transfusion. Rarely, if you have the hemoglobin less than 5 and the child is unstable, like having sign and symptom of respiratory distress, hypoxia, lethargy, significant tachycardia, they will be eligible for blood transfusion, pack the red blood cells, and it's very, very important to give this slowly, not fast. So you will give a smaller dose, not like the traditional dose, smaller, like 5 mL per kilo over 4 hours. So you give it slowly, so to prevent congestive heart failure. To prevent iron deficiency anemia, for breastfed babies preterm, usually most of them they will leave NICU preterm babies on oral iron. This is the standard. They leave NICU and oral iron. And for full term, when the mother is coming for 4 months follow-up, you start to tell her now it's better to start the iron. If the mom is giving formula, most of the formula are fortified with iron, so you don't have to supply with iron. So, but for breast milk, it's yes. Very important not to recommend to give whole milk before 1 year. This is the guideline. Whole milk in 1 year older, or older. So less than a year, like at 9 months. A lot of people they recommend at 9 months. It's not recommended. It will give you iron deficiency anemia, and the body's the stomach or the digestive system is not ready to digest whole milk yet. So it's better to avoid it. If it's possible, if the child has access to formula, no whole milk. Limitation of excessive milk intake to less than 16 ounces per day. And iron supplementation in the people that are vegetarians, because vegetables are not a good source of iron, even spinach. Okay, the best is meat, liver, all the animal sources. Okay, this is a 7-year-old girl presented with behavioral change. Poor school performance, irritability, abdominal pain. She looks pale. CBC is significant for low hemoglobin, elevated RDW, low reticulocyte count, elevated free erythrocyte protoporphyrin. Peripheral smear is positive for microcytic anemia and basophilic stippling. What is the most likely diagnosis? Lead poisoning. Yeah, perfect. So if you see here, I order lab. It's called the free erythrocyte protoporphyrin. I will explain to you what is the significance of this lab. This lab is important because as you see here, you have protoporphyrin and the iron. In order for the iron to combine with protoporphyrin, there is an enzyme called ferrochelatase. The lead will prevent and will inhibit the ferrochelatase, so the protoporphyrin will be elevated. And in iron deficiency anemia, because not too much iron to combine with protoporphyrin will be elevated. So you will see this test, free erythrocyte protoporphyrin elevated in iron deficiency anemia and lead poisoning. Okay, but will be normal in thalassemia. So it's a good test to differentiate between iron deficiency anemia and thalassemia as well if you're still in doubt. In lead poisoning, to confirm the diagnosis, directly measure the lead level. The standard now for lead level is more than 3.5 microgram. It is considered high. You will see the elevated free erythrocyte protoporphyrin, as we mentioned. In the peripheral smell, you will see basophilic stippling, which is the blue granules distributed throughout the cytoplasm of red blood cells. This is common with lead poisoning, but also can be seen in normal individual, but is highly suggestive. Whenever you see it and the child is having microcytic anemia, measure the lead level. And also can give you ring sideroblast, because the iron, the extra iron, will be trapped inside the erythroblast in the bone marrow and will accumulate in the mitochondria and will give ring sideroblast. So one of the causes of sideroblastic anemia is lead poisoning. And the treatment, of course, you have to control the environment. If the lead level less than 70, you give oral chelating agent. If it's more than 70, hospitalization. Am I going fast or okay? Okay, we have 6-year-old boy with history of weight loss for the last 6 months and abdominal pain. His labs are significant for low hemoglobin, low iron, low TIBC, and high ferritin. So there is a weight loss for last 6 months. And what is the most likely diagnosis? Iron deficiency anemia, anemia of chronic disease, beta thalassemia. So anemia of chronic disease, there is inflammation in it. The child is sick with something, like say inflammatory bowel disease, tuberculosis, chronic osteomyelitis, something chronic. And the hepcidin is like an iron sequester, will hold the iron, will prevent the iron to be absorbed. So that's why any inflammation in the body will release hepcidin. Hepcidin is the enemy of iron, doesn't like a rush, will trap the iron, will prevent the iron absorption, will decrease the iron. So the body has iron, but is trapped. It's not free to make hemoglobin. That's why the child will be anemic. So in anemia of chronic disease, you will have low hemoglobin, can be down to 6, low MCV, but can be normocytic. In some textbook, they classify anemia of chronic disease as normocytic, but as the disease progresses, it will progress to be microcytic. You will have low serum iron because it's trapped already in the endothelial, in the macrophages and in the reticuloendothelial system. You have elevated serum ferritin. You have elevated serum because of the inflammation. Ferritin is same like CRP. Okay, is a inflammatory marker and will be elevated. So, and whenever the ferritin is elevated, also TIBC will be low. So here in anemia of chronic disease, ferritin will be high, and the TIBC, iron, transferrin saturation, low, transferrin, low. So in anemia of chronic disease, the only thing is high is ferritin, everything else is low. So here, ferritin, whenever the ferritin is elevated, TIBC is low. Whenever the iron is low, transferrin saturation is low. There is not, the transferrin cannot find any iron to carry, so this it will not be saturated. Will not the transport will not be full of iron, will be empty, and the transferrin itself will be low. The treatment is simple treatment of the cause, and in significant cases you may give recombinant erythropoietin. This is 5-year-old, the child has blood work for abdominal pain. His CBC shows red blood cells at 5.2 million and hemoglobin 9 grams per deciliter, MCV 60, and normal reticulocyte count and normal RBW. What is the most likely diagnosis? Which one? Thalassemia 3. So why I said thalassemia 3, just by looking at that, you will have the MCV 60 divided by 5.2 is less than 13. And thalassemia 3 is usually less than 13, but more than 9. Less than 9, you are dealing with something severe. By 6 months, they already diagnosed because they will have thalassemia major or more significant, like the significant form of alpha thalassemia. So what is thalassemia? Decrease the production of alpha or beta globin. If it's alpha, will be alpha thalassemia. If it's beta, will be beta thalassemia. So if you have here, the hemoglobin F is alpha and gamma. Hemoglobin A is alpha and beta. Hemoglobin A2 is alpha and delta. Okay, so in order to have normal, healthy production of globin, you have to have the alpha to non-alpha pair 1-to-1. Okay, if you have like an alpha thalassemia, you have decrease in alpha. When you have decrease in alpha, then you have accumulation more of gamma. So you have gamma 2 plus gamma 2 will give you the tetramer or gamma 4, and this hemoglobin part. And the hemoglobin part will destroy the hemoglobin and will hemolyze. So alpha thalassemia mainly, you have alpha in all of them. You have, but if it's presenting early with 4 gene deletion, you will have the child will not survive, or the infant may die even in Europe. So the alpha thalassemia usually because of deletion in chromosome 16. There are 4 genes. If you have 1 gene deletion, this is asymptomatic. This will not have no even anemia at all. You will not know about this. So clinical is not significant. But the one is really important for all of us is the 2 gene deletion. You can have 2 gene deletion on the same site or opposite. In the same site, it will be cis deletion. If it's the opposite, will be trans deletion. This will give you mild anemia, a slight increase in red blood cell. This is the most common one, usually mistaken for iron and is treated with oral iron. The 3 gene deletion, you will have excess of beta 2, and this will give you hemoglobin H, and this will cause severe anemia. 4 gene deletion, this is incompatible with life. You will have 4 gamma, will give you hemoglobin abort and the hydroxybutyric. So this is the most common one we will see all the time, and it's confusing. Why? Because when we order hemoglobin electrophoresis, will be normal. So this is what is confusing with the alpha thalassemia. So alpha thalassemia trait is deletion of 2 genes, as we mentioned in the previous slide. Usually no symptoms. Just can be incidental. Fine, you order the CBC for any reason. Then you found the child's microcytic, hypochromic, and the hemoglobin is low. So, like if you have this case, 10 grams of hemoglobin and the MCV 64, 5.3, as again, 64 over 5.3 is 12 less than 13. This is thalassemia trait. Okay? And the hemoglobin electrophoresis will be normal in alpha thalassemia, will be abnormal in beta thalassemia. And this often misdiagnosed as iron deficiency anemia. So, if you have this case we mentioned before, and you suspect thalassemia, is very likely. What to do next? So to confirm, you do order ferritin. If ferritin is normal, you don't have to do anything further. You reassure the parents, no iron. This is a case of thalassemia trait. It doesn't matter if alpha or beta, because to know this alpha, you need to do electrophoresis. Electrophoresis is normal. This is alpha. If it's abnormal, it will be beta. Beta thalassemia. Both of them, you do not need to give iron. So it's up to you if you want to order the electrophoresis, but you don't have to. Okay. So a normal ferritin, it's thalassemia trait, reassurance done. But if the parents insist, they want to give iron and they are not to, when they go from one pediatrician to another, you may do it for them to convince them, but also you may have difficulty to convince them because the hemoglobin electrophoresis is normal. They may not really absorb the diagnosis. They have 3 gene deletion. They have mild to moderate hypochromic microcytic anemia. They have some extravascular hemolysis. The spleen may be enlarged, jaundice with polylithiasis or pigmented stones. So the anemia is exaggerated by any trigger, like infection, pregnancy, exposure to oxidizing drugs. The treatment, the only thing you can give them is just folic acid. There is nothing you can do for this type. And as needed, blood transfusion. If they are unstable, they're having tachycardia, but they can live with hemoglobin 8 and 7, no problem, because it's chronic. You don't have to transfuse if they have hemoglobin 7 and they are stable, no tachycardia, no hypoxia. Okay, and the splenectomy in severe cases, this is the last resort allogenic hematopoietic stem cell transplant. How to confirm the diagnosis of this one? You can do genetic test. But hemoglobin electrophoresis is normal. So genetic test will confirm the diagnosis. We will see, will show the 3 gene mutations. I'm sorry, 3 gene deletions. This one is incompatible with life, we already discussed. Then now we go to beta thalassemia. Beta thalassemia, the problem is with beta globin chain. So if you have deficiency or reduction in beta globin, you will have more alpha. And when you have more alpha, so here is the slide. This is a problem in chromosome 11 and due to gene mutation. So alpha thalassemia because of gene deletion. This because of gene mutation and the absent B. So this is normal B. If you have 1 gene mutation, you have normal B. If you have the 1 gene mutation will give you decreased beta, and they will mark it as beta plus. And if you have 2 gene deletion, it will give you beta no or beta 0. And in mild cases, like 1 gene deletion, like the trait, you will have normal beta plus reduced beta. Then will give you beta thalassemia minor. In this case, you will have a slight decrease in hemoglobin A. This is the most important hemoglobin you want. hemoglobin A, adult hemoglobin. This is one will carry the oxygen. And how to make the diagnosis by looking at hemoglobin A2 will be more than 3.5, classically will be between 4 to 6%. And hemoglobin F will be slightly increased, it will be up to 2%. Of course, if you have absent like homozygous mutation, you will have beta no or beta 0, no beta at all. In this case, will give you beta thalassemia major. You will be in electrophoresis, you will not see hemoglobin A. It's gone. So this is the most important diagnostic point. In major, no hemoglobin A. Most important diagnostic point in beta thalassemia minor is hemoglobin E2, will be between 4 and 6%. What to do for this? Nothing. This is the one that will require treatment. So diagnosis of beta thalassemia based on the hemoglobin electrophoresis. So you will have hemoglobin A2 will be 4 to 6%, and this will confirm the diagnosis of thalassemia minor. And hemoglobin F will be slightly increased. Cannot be diagnosed with electrophoresis in neonate because you have the predominant hemoglobin is hemoglobin F. So no beta, so it will be normal in neonates. Also, if the child has concurrent iron deficiency anemia, it may give you normal hemoglobin electrophoresis. So in order to have a good result, you have to correct the iron, folic acid or B12 if any.
ساعتها نعرفها بالفيريتين نعرف بقى بالفيريتين ساعتها لو شوفت مع
Yes, yeah, always. Ferritin will give you. If it's normal, this is you are dealing with thalassemia. Okay, but because ferritin will be low in iron deficiency anemia. So simply CBC with ferritin, that's it. You know that you will know the answer. You don't need to order tons of labs. You just
يعني لو العيان دي تسلسلنا تريت عملت له هيموجلوبين خليت الهيموجلوبين E1 2 اللي هو
A2 elevated
نورمال او لو
for instance minor, unless if you one really the parents wants more, because anyway you will not treat, you know. But if it's iron, you will treat as iron deficiency anemia. It's for the purpose of iron deficiency, not for the thalassemia. Yeah.
نورمال فيريت نورمال فيريت
Sorry?
نورمال فيريت
Huh?
فيريت نورمال ليفل
Ferritin level? Wallah, it depends on your lab, but mostly more than 12 at least. Ferritin level 12 or more, but less than 12 is low. But it depends on your labs, because some labs they put certain number for normal range. Huh? So again, the beta thalassemia minor is elevated hemoglobin A2. This is the diagnostic part of beta thalassemia minor. The one I don't like at all is the thalassemia intermediate. I never like to study it because just in between, is in between thalassemia minor and the thalassemia major. So just you will see the hemoglobin A2 in electrophoresis is not absent. It's there, but is not high enough. So we'll give you, and depending on the degree of mutation, you will be severe. These patients they may require sometime blood transfusion, but they are not like they are not the same like thalassemia major. So thalassemia major or polycythemia, this is the big one. This is the one you may see all the time. You will have variable production of beta globin gene production. Then you will have alpha globin, and when you have lots of alpha globin, you will have this extravascular hemolysis, and you will have short lifespan, and the splenic trapping. The spleen may be enlarged, and you will have the thalassemia major. Because this is the most beta globin is important for hemoglobin A, and this is what we need, hemoglobin A. So no hemoglobin A, thalassemia major. So the clinical presentation will depend. In this case, usually present at around 6 months of age because hemoglobin F will be protective in the first 6 months. And you will have severe anemia will increase the iron absorption and subsequent toxicity. This is the patient you don't want to give iron. They already suffering from too much iron in their body. They are pale, they have jaundice, fatigue, hepatosplenomegaly. The typical facial features, because of extramedullary hematopoiesis, they will make some blood cells or red blood cells in unusual places like the face or the skull, and they will have the flat nasal bridge, the busing, and the wide space between the teeth and the chipmunk face. And they may have pathological fracture. Iron toxicity may cause hypothyroidism, hypoparathyroidism, diabetes, and cardiovascular can cause congestive heart failure. And here you see start to have target cells here because the red blood cells, the membrane will be a little bit weak and may allow some hemoglobin to come in the middle of the central pallor, and you will see start to see target cells. You will not unusual to see target cells in the peripheral smear and iron deficiency area, but you will see it in thalassemia. So you will have a few reticulocytosis compared to the degree of anemia, microcytosis, and no normal appearing red blood cells in the smear. They are exaggerated hollow. You see there is almost no hemoglobin. No hemoglobin. It's just the central pallor is too much. The red blood cells are pale. And you have target cells, and the Minzer index less than 9. And you will have indirect bilirubin because it has some extravascular hemolysis. You will have indirect bilirubin will be elevated. So this is a hemoglobin electrophoresis. This is normal. You have, this is the origin. This is the hemoglobin A2, hemoglobin F, mostly hemoglobin A. So you have more than 95% or 98% hemoglobin A. This is a normal person. Thalassemia trait, you will have the hemoglobin A2, 4 to 6%, and you have the hemoglobin is slightly reduced. In thalassemia major, as you see here, no hemoglobin A, none. This is how the electrophoresis look like. So these patients, unfortunately, they are living on blood, so they have long-term transfusion therapy. They will need iron chelating agent, sometimes splenectomy, other therapies like allogenic hematopoietic transplantation, gene therapy, and supportive measures. Beta thalassemia trait, no treatment is required, as we mentioned. Only if you have concurrent iron deficiency anemia. Have macrocytic anemia here. The hemoglobin MCV is more than 100, and it's divided to megaloblastic and non-megaloblastic. So the megaloblastic means that the neutrophil nucleus is hypersegmented, okay, and in non-megaloblastic there is not hypersegmented. This is because of DNA problem. This is because of either liver or hypothyroidism. Here is mostly because of folic acid B12 deficiency. So the hypersegmentation is the key. Hypersegmentation. Megaloblastic hypersegmentation of the neutrophil. So B12 is very important for methylation of homocysteine to methionine and folate, and both of them, they will help with the DNA synthesis of red blood cell. So if you have lack of DNA synthesis, decrease in DNA synthesis, the red blood cells will divide less and will be large, macrocytic. So this is a peripheral smear. The red blood cells is larger than the nucleus of mature lymphocyte. They are large. This is not magnified as the previous one for microcytosis. So this is larger red blood cell. You have a 12-month-old boy with a history of reflux, looks very pale. His mother is worried about him having anemia. His CBC showed hemoglobin level 8 grams per deciliter, and the peripheral smear is significant for macrocytic cells, hypersegmented neutrophil. Mother mentioned he was drinking goat milk for his reflux for the last 6 months. What is the most likely diagnosis? Folic acid. So these things are not common, but you may see it. The folic acid, mainly vegetables and sometimes animal organs. The body can store the folic acid for up to 3 months. It could be adequate intake, good milk, especially in the first year. Decrease the folic acid absorption, like because of inflammatory bowel disease. Medications like anticonvulsants or congenital condition like congenital dihydrofolate reductase deficiency, or medication. Whenever you give methotrexate, you have to supplement with folic acid. So it's a megaloblastic anemia, but without neurological problem. Okay, so they have megaloblastic anemia, glossitis, irritability, may have chronic diarrhea, and hemorrhage from thrombocytopenia. So in this case, you will have the macrocytic megaloblastic change in the peripheral smear. The neutrophil is hypersegmented, low folic acid, and whenever you suspect any macrocytic anemia, you have to order folic acid with B12 together, not just folic acid, not B12 by itself. So before you treat folic acid, you have to rule out B12 deficiency first. Because if you have concurrent or actual B12 deficiency, you will improve the macrocytosis, but the neurological symptom will be worse because you are not giving B12. A child whose family strictly vegan has macrocytic anemia and the peripheral smear is positive for hypersegmented neutrophils of more than 5 loops. What is the most likely cause of anemia? B12. So B12 is mainly the mainly source. You will see that only in rare in Egypt because most of the people they eat meat, but in India there's a lot of cases of B12 deficiency because strict vegans are a lot of people with strict vegan. Even some moms they come to my clinic and they are not given they are strict vegan and they are not taking any vitamin. The baby may develop iron deficiency anemia. They are breastfeeding and they don't have any source of meat. But it takes about 3 to 5 years to finish the storage, so it takes a long time. So inadequate B12 intake strict vegan, exclusively breastfed and maternal diet, vegan diet, removal of terminal ileum, this is the site of absorption, inflammatory bowel disease, some worms, and if you have a child with family history of autoimmune disease or vitiligo, and the peripheral smear showing macrocytosis, you can order antiparietal antibodies because this can be a pernicious anemia. So it will be symptoms of anemia, weakness, tired, failure to thrive, and the neurological manifestations. Laboratory, you'll have macrocytic anemia, megaloblastic change, same like folic acid. LDH will be elevated because of the turnover of the cells in the bone marrow. Normal iron and folic acid in this case may have methyl malonic acid will be increased, the homocysteine will be increased, and the low retic count. And in case of autoimmune conditions, you will have low elevated antiparietal antibodies in pernicious anemia. The treatment of B12 is B12 with supplementation. Usually, if the child is significant with neurological symptom and usually we start with a good dose of vitamin B12, and then you can do IM monthly with B12. And you have to treat the underlying cause. So this diagram, if you have macrocytic anemia, if it's megaloblastic, you order folic acid and B12. If low B12, treat B12. If it's low folic acid, give folic acid. If both of them are low, you have to refer to hematologist because they may need a bone marrow. Okay? And if you have non-megaloblastic, you check the reticulocyte count. If it's low, this could be because of hypothyroidism or hepatic disease. If it's high, because of hemolysis or hemorrhage. This is important, normocytic anemia. دكتور عثمان قول لي امتى البريك؟
ها؟ لسه كتير؟
ها؟
الانيميا لسه فيها كتير؟
يعني ربع ساعة كمان؟ نكمل ربع ساعة كمان؟ So we have a 2-year-old boy with hemoglobin 4, normal MCV, low retic count, normal EDA or adenosine deaminase activity, negative direct Holmes valley, no signs of hemolysis. What is the most likely diagnosis? Folic acid deficiency, Fanconi anemia, transient erythroblastopenia of childhood, or diamond black fan anemia. So 2 years old, and the hemoglobin is very low, it's 4. It's 4. And the MCV is normal, it's not microcytic. And retic count is low. Transient erythroblastopenia, this one you can see it. You may see a case like that, okay? So this is transient erythroblastopenia of childhood. So transient erythroblastopenia of childhood is most commonly acquired red cell aplasia in childhood. The transient suppression of red blood cell production. This is more common than diamond black fan anemia. Diamond black fan anemia is pure red blood cell aplasia, but is rare, and the child will have a skeletal abnormality. The exact cause is unknown. Viral or immunologic mechanism may be involved, but we don't know exactly why a child like 2 or 4 years old will suffer from transient erythroblastopenia with childhood. So the age between 3 months to 3 years, okay, most common between more than 12 months, and more common in boys. Most common presentation, no symptom. The child, you do the CBC, or maybe the child will look pale, you do CBC, will be no symptom, running, playing, doing well, and it may have gradual increasing color. Uncommon presentation, increased fatigue or decreased energy, or breath holding spell. The key point here, MCV is normal. This is important. And the hemoglobin level can go between 5 to 7 grams, but can be as low as extreme 2 grams. Okay, and the reticulocyte count is decreased. Bone marrow biopsy rarely required, and normal adenosine deaminase. Why we measure them? Because adenosine deaminase or ADA will be elevated in diamond black fan anemia. That's why we order.
ممكن نعمل فرقتين. ممكن نعمل فرقتين.
Yeah, why not? Yeah, we can do ferritin. Yeah, almost CBC with ferritin. This will answer a lot of questions. Huh? You don't have to. I had a case like that before, and the hematologist didn't do bone marrow. Just as long as it's healthier and you do another CBC and there is no decline in other cell lines, you don't have to do the bone marrow. So the treatment is reassurance, but if the child is symptomatic and the hemoglobin is low, most of the hematology will do it. Most of the children, they recover within 2 to 3 months. Occasionally transfusion if it's symptomatic. If it's no symptom, you don't transfuse.
Hypoxia is not expected. يعني الأكتر that functional oxygen carry. Will definite hypoxia here. How to deal with his normal life?
And then when we do something,
Because it's gradual decrease, most of the children, they will not have symptoms with this illness.
Even hemoglobin,
Huh?
even hemoglobin is very low.
Yeah, even if it's very low. Same like you have a child with sickle cell anemia and running and playing with hemoglobin 7. You don't need to transfuse sickle cell anemia because it's chronic. But anything acute will give you symptoms. All of a sudden, hemoglobin drop to 7 or even 8, the child will be looking very sick. But if it's chronic and they gradually drop, the child might compensate and look okay. But some of them, they will have fatigue. They have symptoms. When it's symptomatic, you have to treat. This is rare diamond black fan anemia, and the transient this is more common. This is not congenital. This is congenital. You will have more abnormalities like thumb anomalies, craniofacial abnormalities, urogenital abnormalities. This is normocytic. This is usually macrocytic. Normal fetal hemoglobin, this will be elevated. Normal serum iron, high serum iron. Here the ADA will be normal and the high adenosine deaminase in diamond black fan anemia. Transfusion rarely required. Transfusion all the time and steroid. So hemolytic anemia. So hemolytic anemia, you have anemia with jaundice, reticulocytosis. So hemolytic anemia, you usually will have the classic triad. LDH will be elevated, indirect bilirubin will be elevated, and whenever you have hemolysis and loss of hemoglobin, the haptoglobin will be reduced. The haptoglobin try to save as much as hemoglobin as possible. So when you have hemolytic anemia, the haptoglobin will be decreased. So this one of the investigation is to order haptoglobin if you suspect hemolytic anemia. So LDH high, jaundice, and low haptoglobin. Then you will have the anemia with reticulocytosis. In microcytic anemia with reticulocytopenia. And you do peripheral smear. This slide will summarize everything in hemolytic anemia. If the peripheral smear is spherocyte, it's spherocytosis. If it's spherocyte plus positive COMS test, This is autoimmune hemolytic anemia. If the peripheral smear showing sickle cells, this is sickle cell anemia. If the peripheral smear showing white cells and the Heinz bodies, this is G6PD without ordering G6PD enzyme activity. And if you see schustocytes and abnormal renal function, this is hemolytic uremic syndrome. So this is the summary of all hemolytic anemia. So you again, ماشي. So the classic triad in hemolytic anemia, you have someone with anemia. Then next step is to order LDH, indirect bilirubin, and haptoglobin. If you see this result, high, and low, you are dealing with most likely hemolytic anemia. Then you order peripheral smear. A lot of science, a lot of things behind peripheral smear can give you a lot of answers. So your spherocytes, spherocytosis. If it's spherocyte and like autoimmune hemolytic anemia, we'll discuss it now. If it's spherocytes plus positive Coombs test, which is anti-globulin test, this is autoimmune hemolytic anemia. If it's sickle cells, will sickle cell anemia. If you have white cells and Heinz bodies, it will be G6PD. If schistocytes, I will explain that later, will be plus abnormal renal function, will be hemolytic uremic syndrome. When you have hemolytic anemia, you have two things. During medical school, it was very hard to understand this thing. So hemolytic anemia either extravascular or intravascular. The intravascular means that hemolysis within the blood vessel. Extravascular means outside the blood vessel. Within the blood vessels, you will have decreased. You will have destruction of you will have destruction of red blood cells, and to combine hemoglobin with haptoglobin, this will decrease the haptoglobin. Then whatever remaining, because the haptoglobin cannot combine with all the combine with few. Then you will have extra hemoglobin, will give you hemoglobin-uria, and this can be seen in G6PD, paroxysmal nocturnal hemoglobin-uria, or microangiopathic. I never like this name, but if you break it down, micro means a small blood vessel. Microangio means a small blood vessel. The pathic means like injury to endothelium in a small blood vessel. Any toxins, any condition cause any trouble in the small blood, in the endothelium of blood vessels, will give you microangiopathic hemolytic anemia, like TTP, thrombotic thrombocytopenic purpura, or hemolytic uremic syndrome. Okay, and extravascular hemolysis means the hemolysis outside the blood vessels, mainly in the liver or spleen or lymph nodes. This will be associated usually with the splenomegaly, like cases of spherocytosis, cases of sickle cell anemia, and thalassemia. So hereditary spherocytosis. So spherocytosis is autosomal dominant. So family history is important. And what happened in the spherocytosis, the red blood cells are biconcave. Biconcave looks like a donut, and central pallor. And when you have problem in the membrane, the cytoskeletal system, if you have any defect, will make the membrane weak and will not be able to maintain the biconcave shape. And this because of spectrin deficiency, anchoring deficiency, or band 3 deficiency. So when the membrane is weak, the red blood cells cannot resist to stay biconcave, and when the red blood cells, the biconcave and the membrane is strong, will be able to maneuver through the spleen without destruction. But once it loses the ability to stay biconcave and become spherical, the only problem in this disease is the spleen. When it goes through the spleen and passing through the sinusoid inside the spleen, and it starts to break down and will cause hemolytic anemia, and the spleen starts to be large. Okay, this is spherocytosis. So if you remove the spleen, this child will live normal with no problem. No problem. But we have indications to remove the spleen. So most of the children will be asymptomatic. If they have hemolytic episodes, they will suffer from anemia pallor and also the triad of hemolytic anemia, jaundice, and because you have a lot of unconjugated bilirubin, the liver will produce a lot of a lot of bile, and this will cause gallstone, fatigue, exercise intolerance, and of course splenomegaly. Anyone knows what disease is caused by parvovirus B19? You see it all the time in your clinic. Slab-dick disease, yeah. So if you and I have a slab-dick disease, like our children, healthy children, they have enough reserve of red blood cells in their body to have, like, if parvovirus 19 will cause suppression of red blood cells transiently for a few weeks, for about 2, like we'll say 4 weeks, so, or 2 weeks. You have enough reserve of red blood cells, so you will not feel anything. The healthy child will not feel anything about parvovirus. But when you have any child with hemolytic anemia, the lifespan of red blood cells is reduced, so they cannot afford to have parvovirus 19. This will cause a plastic crisis, like profound anemia, because they don't have enough reserve. So spherocytosis, the labs you will see reticulocytosis, like all hemolytic anemia. This is the triad: indirect hyperbilirubinemia, high LDH, low haptoglobin. Of course, this is normocytic, not microcytic, and elevated MCHC. And the peripheral smear, you will see round cell like that one is smaller than in the nucleus of the lymphocyte. So most of the cases of hereditary spherocytosis, the size of red blood cells are smaller than usual, with loss of central pallor. Why it's loss of central pallor? Because the hemoglobin will be more concentrated inside, so the pallor inside will disappear because it will be more concentrated. So when you look at the CBC, you will see MCHC is elevated, and the high percentage of spherocyte, and how to confirm the diagnosis with osmotic fragility test to expose the red blood cell to hypotonic fluid, and it will swell and break down. So what to do for this patient? Folic acid. When to remove this spleen if the hemoglobin is less than 10, reticulocytosis, aplastic crisis, port growth, cardiomegaly, and the one will decide for that is the hematologist. So most important for anyone when the spleen is removed to vaccinate the child against encapsulated organism like Haemophilus influenza, pneumococcus before splenectomy. Then you have to give prophylactic antibiotics like penicillin VK. 125 is less than 5 years. 250 is more than 5. So whenever you remove the spleen, there is something called the Howell-Jolly body. So this is a remnant of the nucleus, because you know the red blood cells are it has nucleus inside the bone marrow. So and they are mostly removed, but and the remnant will be removed by the spleen. But when you have a splenectomy, like in this case, this is a case of sickle cell anemia, they have also splenectomy, and they have remnant of Howell-Jolly body. Whenever the spleen is gone, you will see the peripheral smear Howell-Jolly body. Which of the following conditions make the patient with sickle cell anemia unlikely to require back the red blood transfusion? Acute splenic sequestration, acute chest syndrome, hemoglobin level 7, transient ischemic attack. Yeah, exactly. So these patients, they are chronic, they have chronic anemia. You don't need to transfuse if they don't have symptoms. So sickle cell anemia is because of hemoglobin S. The problem, you will have hemoglobin S. Why hemoglobin S? Because of mutation and substitution of valine for glutamic acid. So normally you have glutamic acid. When it's substituted with valine and you have valine is bad. Glutamic acid is hydrophilic, likes water. And the valine is hydrophobic. So it's valine at 6th position, and instead of normal, glutamic acid will give you sickle. This pale a little bit, but anyway, so you have valine at 6th position in beta globin chain due to mutation. This will give you hemoglobin S. Any exposure of hemoglobin S to any stress like hypoxemia, dehydration, acidosis, the hemoglobin S is hydrophobic. It has valine and will polymerize. And what do you mean by polymerize? Will aggregate. And when it aggregates, it will change the red blood cell from spherical to needle-like structure, or sickle cell, or banana-like, and will give you this shape. And what is the problem with the sickle cell? With the cells are like that, and when they aggregate together and when they sickle and desickle, the membrane will start to be weak. So that if they are exposed to, like, say, low oxygen, it will sickle. Then when the oxygen is corrected, it will de-sickle again. And the process back and forth, the red blood cells will break down. And also when the red blood cells sickle like that and they go through the small blood vessels, they will make small microplaques. They will cause vasoocclusion. And vasoocclusion will give you dactylitis, autosplenectomy, the spleen starts to shrink, and it will give you acute chest syndrome, will give you pain crisis, and may affect the kidney, and will give you renal papillary necrosis. And hemolysis can be because of extravascular or intravascular or both, and it will give you anemia, same triad of hemolytic like anemia, jaundice. Also the unconjugated bilirubin will be taken by the liver and will give you gallstones and decrease the haptoglobin, same triad of any hemolytic anemia, and some target cells. And the body also start to make red blood cells outside the bone marrow, the facial bone skull, and will give you extramedullary hematopoiesis. So now with the neonatal screen, you are able to make the diagnosis before any symptoms of sickle cell anemia. And manifestation, if the child wait enough, the manifestation will start as early as 6 months because hemoglobin F will be protective in the first 6 months. The crisis will have sequestration, pain crisis, aplastic crisis, and the aplastic crisis usually because of parvovirus B19. So infection, if you have any child with fever, with sickle cell anemia, can be serious, and the morbidity will be high because the spleen is not functioning well in children with sickle cell anemia. So in laboratory, you will see anemia, sickle cell smear in a child with sickle cell anemia. With sickle cell trait, you might not see the sickle. So you have to do a special prep to ask the pathology to ask him, I need a sickle prep, because they can add beta bisulfite, and this will be positive in both disease and the trait. And in disease, you will have 90% hemoglobin S. This is the one. This is the bad one. And the hemoglobin F will be elevated, 2% hemoglobin E2, no hemoglobin A. This is also key diagnostic factor. In trait, you will have hemoglobin S less than 50. Any hemoglobin F less than 50 doesn't sickle. So no one with sickle cell anemia trait will sickle. They may sickle only if they are exposed to dehydration and they are athletes. It may cause micro hemoglobinuria in the kidney, but otherwise they don't sickle. This is the hemoglobin electrophoresis. This is the origin. Hemoglobin E2 here is normal. Hemoglobin S about 40%, like less than 50%. So there is no specific number. Less than 50%, sickle cell trait. And the hemoglobin is slightly reduced. In sickle cell anemia, hemoglobin A2, 3 to 4%, but hemoglobin S is majority of the hemoglobin. And the hemoglobin F is increased, but hemoglobin A is absent, no hemoglobin A. In the peripheral smear, you will see target cells, you will see Howell Jolly body, and you will see this is banana-like structure. This is sickle cell, this is another one, sickle cell. So this is a case of sickle cell anemia. And why Howell Jolly body? Because of autosplenectomy, absent of spleen. The spleen function is to clean that, to clear the nucleus from, remnant of nucleus from the red blood cell. So fever in a child with this, so if you are in the ER, work in the ER or in your office and you have a child with sickle cell anemia coming to you with fever, you admit. There is no, you don't treat them at home. Okay? So this is a medical emergency due to a high risk of severe bacterial infection and a high fatality, increased risk of bacteremia, sepsis, meningitis. Usually they require IV ceftriaxone or cephalosporin or cefotaxime, and the prophylaxis, when they leave, they have to be in prophylaxis depending on the age. Osteomyelitis is commonly caused by staph in most of children, but with sickle cell anemia, it can be also because of salmonella. Pain crisis is a major problem in patients with sickle cell anemia, and whenever they have pain, acetaminophen or ibuprofen might not be enough, so you have to give opioids or strong painkillers. And the hydroxyurea, usually prescribed by a hematologist, will increase the hemoglobin F, and total hemoglobin will decrease the pain crisis by 50%. Side effects, it may cause myelosuppression, but it's reversible. So it's very safe, hydroxyurea. aplastic crisis, when a child with sickle cell anemia exposed to parvovirus B19, they will have profound anemia, fatigue, decreased activity, poor feeding, and altered mentation or altered mental status. In aplastic crisis, you'll have severe anemia, reticulocytopenia, low bilirubin, and occasional thrombocytopenia. And aplastic crisis treatment, transfusion. Sequestration means that the blood will pool in the spleen, and you will have the spleen will be rapidly enlarged. This is the key. And the child will have hypovolemia and shock and maybe even death. And the hemoglobin level will drop. The diagnosis is usually, if this is a chronic patient, you have to teach the mom how to palpate the spleen. The spleen will be rapidly enlarged. When the spleen rapidly enlarged, you have to take the child to emergency room. And the drop in hemoglobin, retic count will be elevated, high bilirubin level, and they confirm the diagnosis with abdominal ultrasound. And in splenic sequestration, labs will be low hemoglobin, high retic count, high bilirubin. In aplastic crisis, very low hemoglobin, low retic count, low bilirubin.
الهيموجلوبين على مدار الجلوكوز سبيريشن الهيموجلوبين دايما بيبقى اقل من 3 او 4.
Yeah, will be like
the most common cause very low
in sequestration. Yeah, because all the blood in the spleen already. This one usually presents early, after 6 months of age. And usually dactylitis presents with pain, and 50% by 2 years of age they will have. And classically you may have it at 6 months, 7 months, a child with or infant with swollen hands and feet. This is called dactylitis. And the treatment, pain medication, you don't need to transfuse for that, unless if the child is having drop in hemoglobin or significant drop in hemoglobin. But the treatment is just pain medicine. Vaso-occlusive crisis is disruption of blood flow in microvasculature anywhere in the body. Can present with abdominal pain, back pain, so a pain anywhere in the body. And the treatment, IV hydration and pain medication. So it is important to be compassionate with the child if they have. You need to give them a strong pain medicine because they will be screaming and crying from the pain. So opioids are the best, or any similar strong pain medications. I will stop here وإن شاء الله نصلي الظهر ونرجع.
شكرا دكتور أسامة، ويعني قدامنا بريك كده سريعا. شرفنا الآن ناخدنا الحبيب الدكتور أحمد التاجي، ومعاه ضيوفه الأستاذ الدكتور أيمن سالم، أستاذ الفاسكولار زيادين، مرشح المحاضرة عامة عن شركة دلتا، ومعانا هنا الدكتور أحمد الشربيني مرشح محاضرة عامة، وطبعا معانا أمين عام القوى بتاعنا وعضو الرابطة الدكتور باسم شكوى. يعني نونسون، وبعد كده بريك ورا بريك مع الشركة وناخد رأي الناس المطلوب يعني اللي عايز الشهادة علشان يسجل اسمه، عشان بعد كده يعني نحط المجموعة اللي هي نبلغ المديرية علشان شهادة البورد. اللي ما بيجيش معاه الشهادة ما يسجلش اسمه. ونشوف برضه هل المعدل اللي احنا ماشيين بيه الريت كده معمول ولا كله ولا اي مخطط، بحيث ان احنا لسه كورس قدامنا مختلف وعايزين نحقق افضل استفادة يعني. هنطرح عليكم يعني او حضروا الاجابات على الاسئله دي. احمد اتفضل.